Namaste and greetings from the World Health Organization. In this presentation, I'm going to give you a global overview on the provision of contraceptive counseling and contraceptive services to adolescents. In this slide, we go through some definitions. Contraception is the intentional prevention of pregnancy by artificial or natural means. Contraception enables people to attain their desired number of children and to determine the spacing of their pregnancies by delaying or preventing childbearing. Contraceptive methods are designated or categorized by duration and context of use, permanent, long-acting, short-acting, or emergency, and by mode of operation as shown on this slide. My apologies for the enormous amount of text on this slide. This is one of two slides which provide a rationale for addressing adolescent contraception. The slide contains 2 points. One is that early pregnancies, both intended and unintended among adolescents, are an important problem. I'm not going to read out the text on this slide. You can do so yourself. But what you can see is that there are the estimates of the number of girls aged 15 to 19 who become pregnant and who give birth are provided in this slide. It's important to note that births occur, a non-negligible number of births occur even in girls below the age of 16. And as we have noted, a substantial proportion of this are unintended. The second point is that early pregnancies among adolescents have major health and social consequences. They are a leading contributor to death. Girls face a high risk of maternal health related problems, pregnancy and childbirth related problems than women aged 20 to 24, and so do their babies. In addition, an enormous number of pregnancies end in abortion. Many of them are illegal and unsafe, leading to health and social consequences, and in some places, legal consequences. This slide continues with the rationale for investment in this area. It provides an indication of the adolescent birth rate, that is the birth rate per 1,000 women and girls aged 15 to 19. And you can see the spread on the slide with high rates, the highest rates in sub-Saharan Africa and the lowest in East and Southeast Asia and the other regions of the world in low and middle income countries falling between. This slide is the second of the two slides on rationale, and it makes 2 points. That the promotion of contraceptive use to address early pregnancies among adolescents has been shown to be effective. The methods themselves are effective, and through evaluations of initiatives and prospective studies, we know that they can be delivered effectively. The second point is that laws and policies in the provision of good quality services need attention. As noted in this slide, 14 million girls aged 15 to 19 have an estimated unmet need for modern contraception. And these figures were put together before the COVID-19 pandemic. So what we have is that we have methods that are effective, intervention studies that have shown that they can be delivered and uptake can be improved, but because of restrictive laws and policies and unsupported social norms and weak policies and programs, these contraceptives are not being made available to the adolescents and young people who need them, and there's hence an enormous amount of unmet need. This slide speaks to the human rights obligations of states. It makes 3 points listed on this slide. The first point speaks to the obligation of states under human rights law to provide adolescents with contraceptive information and services. The second point speaks to the attributes of contraceptive information and services, what is required of them in the context of human rights law. And the third point speaks about this from the perspective of adolescents themselves. What is it that they need and under human rights law have a right to? This slide is one of 2 slides which discusses key concepts to consider in improving access to and uptake of contraception by adolescents. The first one speaks to laws and policies and the fact that in many places they are restricted by age or marital status. One key issue is to make these laws enabling, to make sure that adolescents are able under a country's laws and policies and procedures to obtain contraceptive information and services. The second one speaks to the misconceptions and the knowledge gaps that adolescents have. And it speaks to the importance of comprehensive sexuality education in providing adolescents with the information they need and to correct their myths, the myths and misconceptions that prevent the use of contraception. This is the second of 2 slides on key concepts to consider. It makes 2 points, building on the ones made in the earlier slide. The 2 points in this slide are one, that contraceptive services and healthcare providers are often not adolescent responsive, adolescent friendly, so there are barriers here in competency, but there's also barriers in terms of attitudes and practices of health workers and the organization of services. The second point in this slide is that adolescents are a heterogeneous group. A boy or girl of 11 is very different from a boy or girl or a young man or a young woman of 19. And the needs for contraceptive information and services evolves over time depending on the stages of development and the circumstances of adolescence. And so there is no one size fits all. Adolescents may need very different contraceptive services depending on the evolution of their development and the changes in their life circumstances. This slide lists the whole battery of WHO guidelines on providing contraceptive information and services. Many of them, or most of them, are not adolescent specific, they are adolescent inclusive, they include adolescents. There are some of them, very few of them, which are adolescent specific. Notable among this is the guideline on preventing early pregnancy and poor reproductive outcomes among adolescents in developing countries. All these guidelines are available from WHO free of charge, and the organizers of this course, Geneva Foundation for Medical Education and Research, have also very kindly posted these materials on their website. If you need any of these materials, please contact either WHO or the Geneva Foundation. This slide contains a list of guidelines and program support tools that are complementary to WHO's guidelines. Some of them listed on the top of the slide are in fact produced by WHO. The others are produced by other organizations listed at the bottom of the slide, the last 4 items. Again, all these materials are available open access in the public arena, And the key messages that come from them are included in the subsequent part of this presentation and in the background reading. This slide sets out how COVID-19 is impacting the provision and utilization of family planning. Again, I won't read all the points on this slide, but some of the main issues are that clinical staff have other responsibilities, health facilities are not functioning as normal, and users of services, women and men, are refraining from using services. In addition, there are logistic problems in terms of availability of contraceptives and medicines that should be available in health facilities and are available in health facilities in normal circumstances. This slide sets out some projections by UNFPA on the levels of disruption of contraceptive availability and the effects of this. In the first paragraph, you can see some estimates in terms of numbers of women and numbers of countries affected. And the second and third paragraphs speak to possible effects for a short or longer period of lockdowns. The reality is that in many countries, lockdowns and disruptions have been very different, and data is becoming available on both on disruptions and on availability, and it's a mixed picture. Thankfully, it has not been the worst case scenario as some workers had feared. Here is evidence from April 2021 from the second round of WHO's National Pulse Survey on the continuity of essential health services during the COVID-19 pandemic. And here it looks at January to March 2021. And you can see that, many services were affected, and relevant to our course are the services related to family planning and contraception, services for intimate partner violence and sexual violence, antenatal care, postnatal care, safe abortion care and post-abortion care, and facility-based births. So what you have is 44% of countries reported disruption of services for family planning and contraception. In late 2020, WHO worked with UNFPA to develop technical guidance titled Not on Pause, responding to the sexual and reproductive health needs of adolescents in the context of the COVID-19 crisis. And this brief addresses all the interventions, sexual and reproductive health interventions that are part of the Lancet Guttmacher report. This slide speaks to recommendations in relation to contraception, and there are 5 points. 1 on informing adolescents, 2 on ensuring that adolescents have access to the full range of methods, 3 on ensuring that forecasting takes into account adolescents' needs, 4 is on giving advice in case the preferred method is not available, and lastly, waiving restrictions that shouldn't have been there in the first place, but if they are there, waiving them in the context of this special circumstance. This slide contains 4 more recommendations. Consider providing multi-month supplies, ensuring that services are provided discreetly, especially if someone is accompanying the adolescent. Cannot take it for granted that just because someone has accompanied the adolescent, they are also aware of the adolescent's choices in terms of contraceptive use. And the last 2 are alternative methods, using pharmacies and shops, and then providing hotlines so that adolescents can obtain services without needing to come into health facilities. The technical brief speaks to what can be done when services are resumed. And the point we make here is that wherever possible, the innovations, the good practices that are put in place during COVID should be institutionalized so that they can continue into the future. So seeing COVID-19 and the disruption is an opportunity to change not so good practice. This is my last slide. It's a cartoon of a training session. And you can see that there's one participant who speaks to her belief that contraception should not be given to young women until they've had their first child. The trainer explains that that's not true. And another participant explains why it's important to provide contraceptives to all those who need them. With that, I conclude my contribution to this module, and I'll hand over the baton to my colleague from WHO's Eastern Mediterranean Regional Office to present the regional perspective on adolescent contraception.
Thank you, Dr. Chandra, for taking us through the introduction of global perspective of contraception, counseling, and prevention for adolescents. I'll now be looking at the regional perspective. I'm Dr. Qudsia Uzma from WHO Country Office, Pakistan, and I'm an alumni of the GFMER course on adolescent sexual and reproductive health that was held in 2020. Let us look at some key facts from the Eastern Mediterranean region. This is a region that has second lowest contraceptive prevalence rate and the second highest unmet need for family planning globally after the African region. Much of this is attributed to the high rate of early marriages in the region. We have countries in the region having national policies or guidelines prohibiting access to adolescents on the basis of age. Only 7 out of 16 surveyed countries have a policy that required disaggregation of data for the adolescent age group. Unfortunately, the region has the lowest proportion of countries that include adolescent health in the pre-service training for clinicians, nurses, and community health workers. Other regional challenges in the provision of contraceptive services include some socio-cultural challenges as well as policy and programmatic challenges. In terms of the socio-cultural challenges, we have high rates of early marriages, as I mentioned in the previous slides, and some socio-cultural barriers in terms of social norms, myths, and misconceptions. The region is unfortunately also hit by huge humanitarian crisis, and many countries are affected, which poses a great challenge. We have policy and programmatic challenges in the form of legal and policy restrictions related to age, marital status, parental or spousal consent, as well as access to and quality of services due to lack of infrastructure, supply shortages, or provider biases, etc. Unfortunately, there is a lack of data, which is an important milestone for making sure that relevant strategies and programming can take place. So there's important lack of age disaggregated data on knowledge, attitude, and practices in the region. Let's look at this map, which is showing one circle for each country in the region. And you can see from the size and the shade of the circle how much is the burden of adolescent fertility in the region. So we have countries having much high adolescent fertility rate like Sudan, Somalia, Yemen, and Afghanistan, besides others. We can look at the trend of demand for family planning satisfied by modern methods among 15 to 19-year-old adolescents in 6 countries of the region. While some countries had some progress, like Yemen and Morocco, we can see that for other countries, the situation was just stalled or even reversed in some cases. What do adolescents know and think about contraception? On our left-hand side, we have data from a survey administered in a Lebanese university, which basically shows the difference of knowledge and practice among male and female students. On the right-hand side, you can see data from a survey, a household survey in rural areas in Egypt. This particular survey has highlighted the issue of married adolescent girls, not having enough knowledge or access to modern contraceptive methods. What to talk about long-acting reversible contraceptives. Contraception in humanitarian settings is yet another challenge, as women may find themselves at much greater risk of unintended pregnancies. The Minimum Initial Service Package, MISP, is an excellent global standard for ASRH response in acute emergencies. It is a coordinated set of activities that address priority reproductive health needs in the early days and weeks of an emergency. One of the 6 objectives is prevention of unintended pregnancy and includes key activities for contraceptive services, counseling, and community awareness raising, as well as safe abortion care. A landscaping assessment of contraception in humanitarian settings has reported that 41% of programs were available and accessible for unmarried adolescent girls most of the time or always, while an equal proportion reported that they were never or only available sometimes. This report highlights stark regional variations where only 13% in the Middle East and North Africa were reported to be available as compared to 68% in the sub-Saharan Africa. Reviewing contraceptives and protracted conflict, let us take the case of Gaza. The Multi-Country Gender and Adolescents Global Evidence Longitudinal Research Program, GAGE, has reported that almost 84% of married girls aged 15 to 19 in Gaza were not using contraception, and contraceptive use was being delayed until after 4th or 5th child, mainly due to son preference. There was also very limited access to information on family planning methods and weak counseling, and there was a high prevalence of early pregnancies. Gaza is also having deeply entrenched gender norms that prioritize girls' virginity and family honor and prevent the girls and women from seeking SRH services. According to GAGE, almost 1/3 of the married adolescent girls in Gaza reported ever using a family planning method. Now let us look at the case of Yemen. Yemen is a country that is described to have the world's worst humanitarian crisis, and it has led to huge health and economic challenges for the country. Looking at the left-hand side, we can see some supply-side barriers to the reproductive health services. In Yemen, it was reported that almost half of the health facilities were not functioning, and only 20% of the health facilities that were functioning were providing maternal and child health services. And this shortage was mainly due to the issues of staff availability, insecurity, rampant destruction of infrastructure, and other operational challenges. On the right-hand side, you can also see some demand-side barriers to the reproductive health services. For example, the pre-existing disapproval of family planning and the pre-existing lack of awareness of family planning. Family planning is generally seen as a Western agenda, and in the situation of the war, this disapproval had been further accentuated. The country is also having some political and organizational barriers, like outbreak response being much prioritized over the reproductive health services, as well as having extended stockouts and delayed procurements of contraceptive commodities. Now let us look at some evidence on the impact of COVID-19 on contraception. On the left hand side, you can see a graph from Pakistan that is showing the comparison of 2019 and 2020 in terms of number of clients who use oral contraceptives. And this sharp decline is very clear from March 2020 when COVID-19 hit the country and the services were stopped. Likewise, you can see on the right hand side the graph from Sudan showing the similar decline in 2020 in terms of number of women who received family planning services. Also, evidence from Gauge shows that in Jordan, access to contraceptives were impeded in the initial months and adolescent pregnancies increased resultantly, which was not the case in the previous years. I would like to highlight a success story of a regional initiative, the Evidence Project, managed by Population Council. It aimed at increasing family planning service demand among young people aged 18 to 35 years. The project trained selected factory workers, almost 300, as peer educators who used to provide family planning and reproductive health messages to their co-workers. And these peer educators were also referring their co-workers to infirmary nurses for additional family planning and RH information and counseling. These infirmary nurses were in turn referring the workers to a large team of pharmacists and physicians who were trained to provide the required services. Through this large team of peer educators, the project was able to disseminate health messages to around 23,000 workers through face-to-face communication and SPCC materials and media channels. We have looked at many challenges and taken a deep dive into some country case studies as well as a regional initiative. Now let us look at some opportunities for the EMR region. We are all aware of the global strategy for women's, children's, and adolescents' health that has for the first time highlighted adolescent as a key global agenda. After this strategy was launched, EMRO supported the member countries to develop their own plans in line with the strategy, taking into account future trends in contraceptive method use. There is also the Accelerated Action for the Health of Adolescents, AHA framework, which is actually a translation of the adolescents chapter in the global strategy. In EMR region, this AHA framework was passed in a resolution in 2017. And following that, many countries have initiated the process of developing their plans and strategies to improve adolescents' health and development. There is also a regional implementation framework for newborn, child, and adolescent health. And this framework has been endorsed and it provides an excellent opportunity to advance adolescent health agenda in general and SRH in particular, including family planning. Finally, some regional considerations for the delivery of interventions related to adolescent contraception. The priority for the region would be to prevent child marriages using legal protection or other programmatic and policy frameworks. Alongside this, there is a need to eliminate gender discrimination as well. In addition, we have to address the broad and cross-cutting determinants of adolescent health by engaging with several other relevant sectors. For example, the health and education sector have to work closely for improving knowledge, attitude, and behaviors of adolescents related to SRH. There is also a need to address the stigma related to adolescent sexuality and also the myths and misconceptions about contraception through engaging with the community, with parents, with religious leaders, and with other influencers. There's a high need to improve the accessibility and acceptability of contraceptive services for adolescents, making these health services adolescent friendly and making them available at the primary healthcare level as well as through mobile outreach. There's a high need for EMR to make sure that adolescents in humanitarian crisis are also having access to the contraceptive services and other priority interventions, including the interventions for GBV and STIs and the use of MISP. Finally, there is a dire need to make data on adolescent SRH available and to ensure meaningful engagement of young people in the implementation and accountability of all the programming around adolescent SRH. With this, I thank you all and wish you a very successful course ahead. Thank you.